Good afternoon to all of you. I would like to warmly welcome the President of SLMA, Dr. Manilka Sumanathilaka, Chairperson of the Women's Health Committee of Sri Lanka Medical Association, Professor Anuruddha Edirisinghe, and our distinguished panel of speakers. The respected audience who are joining us today, both physically and via Zoom, to this very timely symposium, aptly named Give to Gain, Supporting Women in Healthcare in the Age of Burnout. Organized by the Women's Health Committee of Sri Lanka in commemoration of the International Women's Day. Although International Women's Day falls on 8th March, the Women's Health Committee of the Sri Lanka Medical Association has for many years organized similar activities with the aim of providing knowledge and guidance useful for women and the general public at large within the month of March. As you may be aware, burnout refers to a state of exhaustion leading from prolonged stress. And what better time than now to have this symposium and learn about the implications of burnout and the remedial actions that need to be taken to address this issue, when almost everyone is grappling with problems, either on the home front or at work, as well as trying to face a possible economic crisis in the near future due to current global geopolitical issues. I would like to cordially invite Dr. Manilka Sumanathilaka, President of the SLMA, to address the gathering.
Yeah, thank you very much. And good afternoon, Professor Anuruddha and all the members of the SLMA Committee on Women's Health and Wellness. Wellness is my theme for the year, so it's very relevant what you are doing. And, you know, the stress and burnout is a very relevant topic these days. And as she, in the initial introduction, which was mentioned, women in healthcare and career, I think in medical schools, the vast majority are female students now. When you talk about our specialty, after few of us, they're all ladies with Dulani and the younger crowd. So we have it's like 25 to 75%. In certain specialties, it's even more. So worldwide also, I know our specialty, it's more ladies taking up these certain specialties, and especially medicine as a subject, a career world over. So you all have the double burden of keeping the home fires burning, plus attending to your professional work, and a huge balancing act, far more than us men, who have ladies to put the wind under our wings, may I say, because most of the things we do lots of stuff, but then home is looked after by you all, So then when you are working, it's going to be a huge, I can understand the burden and the stress that the working women would undergo. So I think we should take this message also to, despite the circumstances, how to manage a work-life balance in career women, and to prevent burnout, especially in the healthcare sector, which is a very demanding area of 24-hour service, shift work, and so many other issues. And I think last year you all were very active when work-based issues came up. Very unfortunate incidents came up, and they had to face all these obstacles and dangers also as women when you're working sort of off hours and shift duties. So all these things should be addressed. And as the SLMA, I'm very happy to help with whatever the proposals that you want to come forward in that to bring up for advocacy in the Ministry of Health or elsewhere to improve the working conditions, plus prevent burnout, what measures or what help we can give. I'm very happy to help. So without taking any more time, let me wish all of you all the very best, and hope you'll have a very interesting afternoon listening to these lectures. Thank you very much.
Thank you, sir. Now, I would like to cordially invite Professor Anuruddha Edirisinghe and the distinguished panelists to the head table. Professor Anuruddha, madam, will be introducing the speakers to start the session. Over to you, madam.
Thank you, Rajika, and also our president of the SLMA, Dr. Manilka, for the introduction. Without any delay, I would like to invite distinguished speakers we have selected for the today's symposium. First to go is Dr. Dulani Chaturika Kottahachi, and she is the present Vice President of the SLMA. So Dulani, I would like to invite you to come to the chair, to the podium here. Secondly, Dr. Kaumandi Kodikara, a medical educationist at the Faculty of Medicine, University of Kelaniya, whom I am very much close to. And I invite Kaumadi, you also to come to the podium. Thirdly, another lovely personality whom I have been in contact with many years. She is a diverse personality, and it is and not a new member to SLMA. She is Dr. Santosha Fernando, a senior lecturer in medical humanities at the Department of Medical Humanities at the Faculty of Medicine, University of Colombo, and first of its kind in Sri Lanka. So we have a very eminent panelists, three panelists here to talk to you. And we have about 1.5 hours for the whole session. And I would be first telling you a little bit about the rules. All of you are having about maximum 30 minutes. 20 to 25 would be the ideal. And then there is a Q&A session, which would be from the audience here, as well as from the members who are joining us on Zoom. So the first person in this symposium today is Dr. Dulani Kottahachi. And if I'm to read her small bio, I know her biodata is more elaborative than this. I asked her to limit to 200 words. So Dr. Dulani Chaturika Kottahachi, MBBS Kelaniya, MD Colombo, MRCP UK, FRCP London, LCE and FACE USA. She is a consultant endocrinologist and a senior lecturer in physiology at the Faculty of Medicine, University of Kelaniya, Sri Lanka. She is a board certified endocrinology with a postgraduate training in Sri Lanka as well as in Australia. Her research interests include endocrine complications of thalassemia and diabetes related complications with numerous peer reviewed publications and academic contributions. She has served as a secretary of the Sri Lanka College of Endocrinologists 2023 and the secretary of the Physiological Society of Sri Lanka in 2019. As I said earlier, she's the current vice president of the Sri Lanka Medical Association. If I add a little bit of my own, she is a student of mine, apparently, and I'm very proud. And the work that she do about especially the endocrinal diseases, detecting, treating at our faculty, in the staff, every year during the diabetic week, she does this immense job. So you start working for people from your home, your workplace to the society. And I know Dulani would do a lovely um, pro- lovely speech regarding her topic. She is to talk of women's health and burnout, empowering through endocrine health, from her speciality to how the stress of these days will affect our bodies. And we have selected the best person, I think, to talk about it. Over to you, Dulani.
A very good afternoon to all of you, joining physically and online. First, I would like to thank Arud Madam for the invitation to deliver this talk. I think being in this month, Women's Month, and celebrating women's is very special to me because first time I'm delivering a talk on the women's health with the Women's Day itself. So my topic is going to be on empowering women through endocrine health, specifically on the burnout women are facing. So to first to start with, what is burnout? We have few classifications, and Freidenberger and Mashaya has done the first work on this, developing kind of a definition for burnout. And that's the extinction of motivation or incentive, especially when one's devotion to cause or relationship fails to produce the desired results. Basically telling that we would love to work, we'd like to be on top, but then we don't have that power to do this. That's basically burnout. There are three dimensions to this, according to the WHO. There's emotional exhaustion, and there's increased feelings of negativism towards one's job or depersonalization, and reduced efficacy or reduction of personal accomplishment. All three dimensions are related to burnout. So when we talk about especially healthcare, as Malika said, almost now 50-50 are in women dealing with the healthcare. We, all of us here, I think, at one point we would feel that we have got burnout. So let's see how endocrine health has had a play in this. So burnout is related to long-term work stress and sustained strain in daily life. Both together, you have daily life which you have to maintain, and also the work stress which is long-term, not just short-term. And the problem is this symptomatology of burnout is shared with other diseases such as depression, chronic fatigue syndrome, and vital exhaustion as well. So all three will have some similar symptoms to burnout. Then as clinicians, we should be able to distinguish this between these three and what is really burnout. When somebody calls in for help, they say, I have burnout. The clinical perspective is there's the higher prevalence in women. Why? Because this dual burden, as Malika said, professional burden, professional work, and then you have a caregiver role as well, as a mother or as the person who's looking after the family. And there's also gender-related psychosocial stresses as well for women, not just looking after the family. And so these symptoms overlap with other endocrine disorders as well, like fatigue. I'll talk about them in detail, cognitive dysfunction like brain fog sometimes, and mood disturbances are related to some of the endocrine disorders as well. So key concept here is burnout involves neuroendocrine dysregulation, not just psychological, not just one aspect. It's a huge spectrum. So you can see these two women, one a female clinician coming and saying, I have chronic stress, she has fatigue, she has weight gain, and she was found to have subclinical hypothyroidism as well. And is a working mother who was sleep deprived, irregular menstrual cycles, and she has psychological burnout. So she has a problem with her gonadotrophin axis as well, reproductive axis. So both women have different problems related to burnout. Let's see how these people come to us, women come to us, and how we can help them. So endocrine system, we say the overview, is an integrated network which mainly maintains the homeostasis in us via the hormone signaling. So the key axes which are involved with stress are the main three ones. It's hypothalamo-pituitary axis, or HPA axis, which is mainly the stress response in us. And we have the hypothalamo-pituitary thyroid axis, HPT axis, with metabolic regulation. And we have the hypothalamo-pituitary gonadal axis, its reproduction and mood regulation in us. So these hormones always act through feedback mechanisms. They have circadian rhythms and also ultradian rhythms as well. So it differs in throughout the day. Some hormones are secreted early in the mornings, some are secreted mainly in pulses throughout the day. So they vary throughout the day. So these mechanisms our metabolic response and our reproductive and mood regulation in a normal person. So what happens when you're burnt out and when you have stress related, acute stress, which activates this hypothalamo-pituitary axis? And the hypothalamus produces the CRH hormones, pituitary stimulates the ACTH hormones, and the cortex, adrenal cortex, secretes the cortisol, which is the stress hormone in our body. So what happens in chronic stress, we alter the cortisol rhythm, and it either a flattened diurnal curve, or it can cause glucocorticoid receptor resistance. And what happens when it happens, you disturb your sleep because there's melatonin interactions. You have immune dysregulation causing inflammatory cytokines, and you have insulin resistance as well with central adiposity, weight gain, and menstrual irregularities via the GnRH suppression. So you can see so many things can happen when you're having this hypothalamo-pituitary adrenal axis in stress. So they have found that in studies, the level of cortisol after awakening in a normal person is usually high in the mornings, and it is very high in a person with burnout, and with exhaustion level it is correlated, and it was positively associated with exhaustion, the awakening cortisol in our body. And higher frequency of arousal during sleep has been associated with high amplitude of cortisol during the daytime. So if you don't have good sleep, you get aroused throughout the sleep, that means you have high awakening cortisol levels. So you can see in this graph the cortisol in saliva, what they have measured in women at awakening and throughout the day. You can see elevated, the blue line, cortisol awakening response is high in patients, in people, not patients, with high burnout, and low response in people with a low burnout score. And to show this, they have looked at the weekend response from the weekday response. So if you can see this workday and weekend, and you can see weekend, you have a lesser cortisol response, but you're fully unable to recover to the baseline. Even if you rest during weekends, it has a lower response, but still you will not be fully to the baseline even after a weekend when you have high cortisol levels during the weekdays. What about thyroids? Because a lot of women come to us and say, Doctor, I might be having a thyroid issue. I'm gaining weight. I'm slow. I have mood changes and I have brain fog. So does it have an effect on the burnout? So what happens? So the thyroid hormones regulate our basal metabolic rate, mitochondrial functions, and neurocognitive performance. So chronic stress will reduce this peripheral conversion of T4 to T3. So possibly a low T3 syndrome in chronic stress women. So this will overlap with burnout, fatigue, the weight changes, cognitive impairment you see in burnout can be due to the thyroid dysfunction you are able to see in people with chronic stress. What about the reproductive axis? It's one of the major concerns in women because estrogen, the women's hormone, is a neuroprotective and it enhances the serotonergic and dopaminergic activity in our brain. And we have the progesterone, which is anxiolytic, that is via the GABA modulation. And what happens in chronic stress, we suppress the secretion of GnRH from the hypothalamus, which reduces the luteinizing and follicular stimulating hormones from the pituitary, which results in an ovulation with chronic stress. They come up to us and say we have irregular cycles, oligomenorrhea, amenorrhea. They are common symptoms in burnout and chronic stress. So they will have premenstrual symptom exacerbation just before menses. They'll have a lot of mood changes, breast tenderness, and the premenstrual syndromes, and reduced resilience to stress as well because of this. So having a reproductive hormone effect due to hypothalamus pituitary gonadal axis have a major effect on women's health. So it's a clinical integration of all of these axes I've talked about for the last few minutes. So biological markers are emerging, and they've shown altered cortisol profiles. And now I think some of the recent studies, they're looking at hair follicle cortisol levels to check the chronic stresses the persons are having. So inflammatory markers are coming up to look at this burnout, and thyroid function variability can be seen in these women. So it's a very wide spectrum you will see in our patients. The mild symptoms like fatigue, irritability, moderate symptoms like sleep disturbance and menstrual irregularities, and in severe cases, they could be having depression and metabolic dysfunction as well. So we need to have a holistic assessment of psychological and endocrine evaluation in people who present to us, in women who present to us with these symptoms. So I think interventions will be dealt by Dr. Santusha in detail, just to give a quick recap of what we can do about this endocrine disruption in women with burnout. Obviously, we have to go for lifestyle modifications with nutrition, and we don't take care of ourselves, but we take care of the whole family's nutrition. The micronutrients are very important, the iron, iodine, selenium, and glycemic control to reduce the cortisol spikes are very important, especially in women with diabetes. Sleep, we have to go for circadian alignment. Melatonin cortisol balance is very important. And the stress reduction strategies, mindfulness, cognitive behavior therapy, regular physical activity, which will improve, scientifically shown to improve the hypothalamus pituitary axis in stress conditions. And we need to do a medical evaluation. Just saying it's burnout and giving all this is good enough, but we have to evaluate these women for this problematic axis they could be having. So indications for testing are persistent fatigue if they're having menstrual disturbances which are going on for years, and weight and metabolic changes. We have to look into their endocrine health to look at this axis. And always we have to individualize this patient's endocrine assessment according. And this I found in one of the key websites on women's health. This is called the cortisol cocktail. It's actually not do it with alcohol. I was thinking it was coconut water, lemon, orange, and they had some magnesium powder in this and salt. So this is a sip away stress with the cortisol cocktail. I'm just giving some tips to reduce your cortisol levels as well. So key takeaway messages from the endocrine point of burnout is a multi-system disorder involving neuroendocrine pathways, and women are disproportionately affected due to biological and psychological factors. And this is central to energy regulation, emotional stability, and reproductive function. And we have to have an integrated care approach for these women with burnout. And we have to promote routine screening for endocrine dysfunction in high risk populations if we take them as high risk women, and especially advocate workplace wellness policies, very important, and gender sensitive healthcare models are very important, which are lacking in our part of the country, of the world. And we have to encourage education of women as well. And us being educated is not good enough. We have to educate the whole healthcare, whole women, not just related to healthcare. Most of women who are working are burnout, and even stay at homes are burnt out at one point. And preventive healthcare strategies are important to look after our women, our mothers, who will be the bigger part in our society in the future as well. So thank you for patient listening. We'll take up the questions at the end.
Thank you, Dulani, for that insight into the endocrines and how burnout, the linkage. The next speaker is Dr. Kumudini Kodikara, a senior lecturer in medical education at the University of Kelaniya. And she is going to talk on evidence and implication addressing the global occupational health crisis. So, as I said, she's a health professional working in the Department of Medical Education, and her work integrates medical education, research, national level policy contribution to strengthen the quality and the resilience of health workers in Sri Lanka. Her research centers on translation of educational interventions to improved clinical practice and quality care. She has published widely in index international journals, contributing to global disclosure on effective teaching and learning in healthcare. She has won several national and international awards for her research excellence, including Postgraduate Research Merit Award from the Sri Lanka Association of the Advancement of Science 2025, Young Scholar Merit Award at the Asia Pacific Medical Education Conference 2024, the Vice Chancellor's Merit Award for Outstanding Young Researcher 2023, and Best Free Communication Award at Asia Pacific Medical Education Conference, Singapore 2018. Dr. Kodikara also contributes to national capacity building of Ministry of Health, WHO initiatives, and National Continuous Professional Development Program. Importantly, as a member of Women's Health Committee of the Sri Lanka Medical Association, she is actively engaged in initiatives aimed at improving women's health and well-being. Dr. Manilka, I think we have to, as our first speaker spoke, especially to advocate about the national policies regarding women's health, which SLMA haven't thought about earlier. We should take up this year. With that, I would to tell the how the research input and to get us more why this topic need to bring to the national level Dr. Kumudini Kodikara will start her presentation.
Thank you, madam. So what I'm going to do within the next 15 to 20 minutes is to walk you through what is evidenced in the span of psychological assessment over the years, why women should be looked at and why women's burnout and well-being has been looked at. So I don't want to go into this. This is a basic introduction about what burnout is, which Dr. Dulani walked us through earlier. But what I want to tell you here is that WHO ICD-11 classifies this as a strictly occupational phenomenon, which results from prolonged stress over a long period of time, which manifests not only as a mental health issue, but also as a physical effect. What is the prevalence? What is the prevalence of burnout at any point in our lives as women? We have felt this, but what is the global prevalence? The global prevalence is for healthcare workers, for women in healthcare, is more than 35%. But this ranges between a good 30 to a good 70% in some instances. Some specialties which are high stress, for an example, emergency medicine, 68% of people working in emergency medicine are reported to have burnout. Critical care, 65%. Oncology, 60%. And also, when the resources are constricted, it has shown higher levels of burnout amongst its healthcare workers. But there's a massive gender gap. That is why we are talking about it in this committee, in this symposium, because this is no longer about hormones. Sorry, Dr. Dulani, what I'm talking about is, the common term, you're hormonal, which is the case actually, but this is fact. 60% of women in healthcare is reported to be burnt out against a 40% of men, which is significant. Given that most of the healthcare workforce is women, consists of women, this is going to be a big problem. There is persistent inequity in it seems because women have higher levels of stress. They can't do their job properly. And this documentation of higher levels of burnout is not just recent, it's not post-pandemic. From the first moment, researchers have touched upon burnout and stress. Women have reported higher levels of burnout. This is not anything to do with recent times. So Dr. Dolani talked about reduced personal accomplishment, about emotional exhaustion, and depersonalization, which are the three components of burnout. Let's talk numbers. 60% of women feel that they are not professionally accomplishing anything, as opposed to 45% of men. The reasons we will talk up later. 69% of women feel emotionally exhausted against 57% of men. Both of these values are significant. Depersonalization, both men and women are rated similarly. So why then? What is this problem with personal accomplishments being lesser? Why is emotional exhaustion more in women? So research has told us about this dual burden. Dr. Manilkar kindly told us what sort of a juggling role that women are doing when you are a working woman, let alone just healthcare, but a working woman. All of us have these duties. We are balancing home and work. And when you are in healthcare, your patients' lives depend on you, which is added stress. If you are in academic medicine, students depend on you. So there's no way out, right? But the society, what does it expect from a woman, a working woman? You need to take care of your family. You need to look after your child. The child is the most important thing in your life. This is not just us, this is the Western world also. The global evidence is such that there is guilt in women when you prioritize demanding roles. If you're a cardiothoracic surgeon, if you're a gynecologist on call 24/7, how many women take up such roles? Not many. And then there is a role conflict. If my job demands me to be in the hospital whilst my kid is sick, the society disapproves. And you can't take that blame, being a mother. And motherhood in itself, every mother, every career woman, if you're a mother, your career disrupts. It does not help you a smoother transition. And all these facts lead up to long-term dissatisfaction. Whether we take it, whether we like it or not, whether we own it up or not, that is there. That is documented. This is not just hormones talking. Childcare and domestic pressures have been documented to be the most predominant factor for burnout in women across the globe, not just in healthcare, but overall professional working women. Married women with children less than 12 years or preschool, including I fall into that category, have higher levels of burnout. This kind of working mothers nearly have more than 50% odds of reporting burnout than their male counterparts. And the fact that your roles are inflexible. Sometimes you can't get away from a shift to attend to a family matter. Nurses and medical assistants have reported higher levels of stress due to role inflexibility. So what happens is that when you have this dual role to play and you have a caregiver role on top of a professional role, what the research says is that even when the woman is the higher income earner in the family or the breadwinner, they have been asked to give up their job or to compromise the job, not the caregiver role. So it often manifests as physical and emotional exhaustion, reduced job satisfaction, and long-term mental health strain. Myth busting. The common belief is that you get burnt out if you are not resilient. You be a tough woman. You won't get burnt out. But that's not the case anymore. Baminwatha et al. Says that environmental factors play up to 70% for you to get burnout as opposed to the 30% that resilience gives. So being resilient or being a tough woman is no longer sufficient to escape from being burnt out. Even highly resilient individuals burn out in toxic organizational environments. That is why this is an occupational health crisis. Let's talk about the evidence on career advancement. We talked about how being a mother prevents you from career progression. What the West says, how they measure this is by pay, by the intention to leave the job, workforce attrition. The adjusted annual salary gap is $19,000 less for a working woman in healthcare than the male counterpart, which is huge. And Whilst this might not resonate with the Sri Lankan community, the lower female representation in senior or higher ranks in academia and in clinical medicine has led to lower satisfaction amongst women and the higher intention to leave, leading to workforce attrition. So it no longer means that even if a woman has the same qualification as the man, the compensation is not equal. Does this apply to us also? Is something we need to think. And now let's talk about the glass ceilings and the leaky pipelines. Majority of the articles state instances of implicit gender bias, which causes significant mental distress to women. This form of implicit gender bias comes in different forms depending on different contexts. In the West, it is unequal pay for equal work. In the West and in the East, it's about refusal to acknowledge a woman healthcare professional by their titles. For an example, in the West, referring a woman physician by their first name, or in the East as Miss, as opposed to using doctor or sir or honorifics for their male counterparts. And the leaky pipelines where lesser opportunities are available for women to advance their careers to senior roles, both of which have made women in healthcare feel demotivated, exhausted, and ultimately burnt out. And they do not no longer want to work. Is it something that we want prevailing in the country where the most of the workforce is women? So Amiri et al. Says increasing patient loads, increasing administrative tasks, and less autonomy, especially in junior healthcare workers, both doctors and allied health, where you can't have your say, leads to increased emotional exhaustion. Workplace bullying, documented in nursing, and poor communication, especially in patient handovers, have also caused emotional exhaustion among women in healthcare. So what do all these do, and what have been researched? What is the impact? 52% of burnt out women have sleep problems, insomnia. As Dr. Dulani mentioned, because of hormonal dysregulation, there is metabolic syndrome, cardiovascular risks, reproductive health issues, and musculoskeletal issues also. Azmi et al. Went one bit further to look at not just physical but mental health aspects. 10% of women in healthcare report anxiety, and 4 to 30% report clinical depression. And because this is in the workplace, attributed by your dual burdens, this becomes a vicious cycle. There is no support, so it becomes a distress cycle. Burnout is positively correlated with clinical anxiety, depression, and chronic stress. So what protects us? Because I also belong in this equation. We need to have emotional and social support within and without. Dr. Santusha will go to this, but I just want to touch on the importance of good leadership in healthcare, in your institution, and also a sense of belonging in your communities of practice. Being left out does not help. So this is the biggest problem. If you are burnt out, your judgment is impaired. keeping in mind that our judgment often is affecting or a person's life, that is problematic. Increased medical errors, increased preventable medical errors, up to 70%. Decreased empathy, and the intention to leave, leading to workforce attrition. And ultimately, you are unable to give quality health care. So, give to gain, coming back to the theme of our symposium, can we give if we do not gain good physical and mental care? We are the majority of healthcare workforce. So the system needs to give us, for us to give back. Let's come closer to home. We were talking a lot about West. Well, what about South Asia? What about Sri Lanka? Are we similar? Are we different? Do we report higher levels of burnout or lower? What do you think? We show remarkably high levels of burnout and mental health indices when compared to the West. Anxiety, 60%. Depression, close to 50%. Junior doctors burnout, about 65%. Senior clinicians and consultants burnt out, about 25%. This is very, very significant. In India, in the year of 2022, there have been 48,000 female deaths attributed to professional stress factors. And a significant proportion of it are healthcare workers. So this is not just about organizational factors, but this also reflects the crises that we face as lower income countries, or because of hierarchy, because of culture. So Sri Lankan literature is quite abundant when it comes to investigating burnout in healthcare workers. I'm just putting up a few, but the problem with this is we are looking at a few people or a small cohort of people in different parts of the country, and we are trying to see the prevalence, which is the most common theme across all the research that has been conducted. Studying prevalence is important, but is that enough? There are a few studies that talk about how cultural stigma, how people in this part of the world look at people who are struggling mentally as incompetent or weak, so that you struggle in silence. And how being a junior member or rigid hierarchical structures prevent you from seeking support, expressing concern, again, make you suffer in silence. How workplace bullying and violence cause distress over a long period of time. And also how severe shortages in support systems that make an individual responsible for providing care and not a support system that looks after the patient and the caregiver. So all these factors, especially in Sri Lanka and in South Asian countries, have caused higher levels of burnout amongst our women in healthcare. So I do not have key take-home messages. I have very big questions. Looking at the research, is burnout in women in healthcare workforce an issue? Yes, apparently so, because we constitute the majority and majority of us are burnt out. Is burnout in women in healthcare well researched? That is a big question because it does not appear to be so. We are talking about prevalence. What gaps remain in our understanding? We do not know how to cope. We do not know what works for us best. And we do not know what makes us more prevalent in burnout than the West. So how do we overcome burnout if this is a big issue? And I will leave that to our next speaker. Thank you very much. We will take up the questions later.
All of us are doing messages now that maybe at the probably so much social media and working groups, WhatsApp, even they say let me working groups of us. WhatsApp group is becoming a stress. So 10, 15 messages, nothing from different area. That was my dopamine depletion.
Thank you, Dr. Manitka, for that question, because it's with the dopamine everybody is talking about. Our final speaker for today is Dr. Santusha Fernando, and we hope that she will give, even after listening to Kaumadi, the issue is huge. I hope Santusha would be able to give few tips to overcome to the audience here as well as who are online. If I'm to introduce Dr. Santusha Fernando, she is a senior lecturer in medical humanities in the Department of Medical Humanities at the Faculty of Medicine, University of Colombo. She is a bilingual writer and a poet, Indian classical dancer, and has a special interest in social anthropology, philosophy, ethics, professionalism, and gender. A board certified specialist in community medicine, she co authored the book Montage of Sexuality in Sri Lanka and has authored book chapters in several publications, including Rutledge Handbook of Contemporary in Contemporary Sri Lanka. She designs and directs the flagship medical humanities program, Humanitas, at Faculty of Medicine, Colombo. She has researched and published on themes covering sexual harassment of female doctors in Sri Lanka, medical humanities, and war as a determinant of health. And if I'm to add a small note, Santusha, last year you published that research on how the female medical doctors feel about sexual harassment. The next week, we came to know a medical doctor being raped in a hospital of Sri Lanka. And me as the chairperson, as well as from the SLMA, we quickly came out and took up the leadership of making a voice and to make our hospitals safe. And from Kaumadis today, even though we didn't had, we were having symposia on harassment and gender-based violence, but never pinpointedly based on research on medical field. And last year was a eye-opening thing, and thank you for that research. But today, after listening to Kaumadi, I feel that this topic, the burnout, as females in this field need to take up to start discussion and to bring change from the policy to how to get out. So, Santosha, I hope you will be able to enlighten us regarding your own way of unique answers.
Thank you, Professor Anuruddhi, and thanks very much to my two preceding speakers who have laid the foundation for my speech. And I also want to say that during my presentation here, I will be very Sri Lanka specific, very specific to our problems, and quickly make you go through. My preceding speakers were very virtuous in their time management, so I hope to be so too. Oops. Okay. All right. So, in 1973, we all know who this is. She's Marilyn Monroe, and we all know how she passed away. Elton John sang a tribute song to her, calling her a candle in the wind. Back in the 90s, when Princess Diana died, he changed the song a bit, and he himself sang another song. But if you just go through these, the lyrics of this song, her name was Norma Jean, actually. She was not Marilyn Monroe. Though I never know you at all, you had the grace to hold yourself while those around you crawled. It sounds a bit like us, although none of us really look like Marilyn Monroe. They crawled out of the woodwork and they whispered into your brain and they set you on the treadmill and they made you change your name. And it seems to me like you lived your life like a candle in the wind. It's burning out. So I would like for you to reflect on yourselves, ourselves as a community. Are we like candles burning in the wind? Maybe. Let's explore. So during my presentation here, I'm going to address a few elephants in the room and some solutions for the elephants. So this elephant, the first elephant is the silent revolution that is happening around education, school education and medical education and professionalism in Sri Lanka. So this elephant says, sometimes even if I stand in the middle of the room, no one really acknowledges me. And here is the situation in Sri Lanka. The Sri Lanka education system as a whole is feminizing. If you take by subject stream, the percentage of females in the arts and commerce are very high. Whereas in physical sciences, it's low. Once again, in the bio stream, it is dominated by women. This is not really much of a point to celebrate as women, because this means that our counterparts are not really acquiring and going through the acquisition of education. So the future partners of Sri Lankan ladies are more and more they're having sort of attrition to school education. If you take the faculty of art, law, management, and medicine, and dental and vet, I will stop there. The percentage of females are dominating in these areas. So our education system, both in schools and in medical education and sciences, are feminizing. So that is the first elephant in the room. A silent revolution is happening, but what is actually being translated in the society is something else. So now, the practical solution one is that we have to reorient the physical and intellectual resources in medicine to suit a feminizing industry. If you go to any college office, any building, any administrative building, any hospitals, you can count how many toilet facilities are there. Even if you go to the parliament, a very few female toilets are there? And do quarters in our hospitals, young mothers like Kaumadi and younger ones with younger children, right? Can we any longer say that no, we will not have breastfeeding spaces, where we will not have support infants in quarters? Can a young doctor bring a mother or a maid, keep that baby breastfeeding still, maybe after 6 months, but still breastfeeding? Can they leave them in a quarters and go for their night on call and come back, right? So do they have reading and studying facilities embedded into maybe the workplace? Because once they go home, they have the dual burden. Do we have a little bit of a safe space for women to do some studies in their professional environment? Do we have safe lit working environments, walking paths with bulbs? Is it oriented? Do we feel safe walking from our ward to our quarters, even to pick a book to study? So we have to reorient our physical environment and our intellectual environment to suit the feminizing industry. And we have to have non-discriminatory environments. So the second elephant in the room is elephant number 2. And now we don't talk about the real problems here. So someone says there's an elephant in the room, and everyone says, no, we don't talk about the elephant in the room. So what is this second elephant say? Okay, so speaking of elephants, let me show you this elephant from the Kolongoda District Hospital in Hasalaka, that is in Mahianganaya. Now, if your daughter, your sister, yourself had to go and work in this hospital, would you call this hospital a safe hospital or a dushkara hospital? Is it an easy hospital or a hard hospital? The Ministry of Health delisted this hospital from the hard hospitals and reduced the number of hard stations to 250 odd from 300 plus. That is because then the doctors can't protest. The females can't protest. You have to go and work in this environment. So I think these are the problems we don't talk about when we talk about women burning out. Maybe the men burn out too, Poor things, right? So this is what I'm trying to say. These are the elephants in the room. Right? So practical solution 1 for Sri Lanka, if you ask me, I would tell to the Ministry of Health, please be a better employer, Ministry of Health. Right? So the Ministry of Health needs to accept that there are issues of governance. For example, like delisting really hard places like that elephant corridor as an easy station. Right? So that means when you are posted to that hospital in Hasalaka, you have no option of coming after 2 years. You can't even finish your dushkara seva, and you don't even have the option of restabilizing your life. Right? And there has to be decision making to retain female workforce. As Kaumadi very rightly mentioned, all over the world, women are forced to give up their agency and their jobs to whenever there is a conflict between profession and personal life. So the Ministry of Health has to proactively make tough decisions to retain the females of a feminizing industry. They have to formulate measures to address the dual burden of life on females. This has been explored by Kaumadi, so I am not going to elaborate on it. There is a systemic delay. If you go to this Ministry of Health, leaving a breastfeeding child or a child to pick from somewhere or a sick child, this Ministry of Health will not attend to any problem. All of us know, right? Is there a female toilet that you can go and sit in the Ministry of Health? Unless you have a friend in a high place and she has a nice locked up bathroom, then you have access to bathroom, right? The poor RHO who goes there, who doesn't have a friend in high place, right, does not have a female bathroom. Is there a water dispenser? Is there a chair for a doctor in the Ministry of Health? No. Right, for all the health system training they do, all the Geneva trips that are taken, right, all the fellowships that are offered, all the specialized exposures that are there, there is a systemic delay. If you walk into this Ministry of Health to get anything done. So the Ministry of Health has to become a better employer. That is my practical solution, number one, right? So these discouraging physical environments have to improve if you are to retain the females of a feminizing industry. All right. So I'm going to be bringing in a little bit of a medical humanities twist. Lakshant Atukorala is an award-winning Sinhala poet. He is absolutely fascinating. He has written this poem. I have put displayed the Tamil translation and the female translation. All of us in this audience are now women. So all of you came here. Many of you have children and families. When you came here, nobody said, you go, I will look after everything. You had to look after and make arrangements back at home to come here. The speakers had to come here to speak. You all had to come here to listen. Nobody said, you are going to SLMA for this event. I will look after everything. You had to arrange either a maid, another woman, or your mother, mother-in-law, sister, cousin, another woman to be handling your home so that you can come and be here at the Women's Health Committee event. Right? So, right? When men finish their work, even if it is private practice, even if they do private practice till 12 o'clock, majority of the men will go home to home. If we go home, we go back to work, right? Right. So practical solution number 2 is still my call to the Ministry of Health. Please be a better employer. Let's see what we can actually do to help the attrition of women and burnout of women and dissatisfied women in a feminizing industry. Right? So you have in our country or any country, a huge investment is made to make a doctor. Whether it is a male or a female, it's a huge investment. And it is our prerogative to do everything to retain healthcare workers, male or female, right? So in addition to the professional labor that women do, women also take care of moral labor, emotional labor. All over the world, patients who encounter a female doctor expect more empathy, at least 10 minutes more of listening and addressing their emotions compared to a male doctor. If a male doctor tells, now it's time you go away, I can't discuss this, that would be a different reasoning. If a female does it, they will think, being a woman, what sort of a female doctor is it? She had no empathy for me. So the moral labor is not accounted for. And the emotional labor that we do at work as well as at home is not accounted for. So the Ministry of Health, I think, again, has to be a better employer that recognizes and makes provisions for this labor that it is intangible, invisible, uncalculated, economically uncompensated work that we do. If in the ward a patient is crying, a patient is hysteric, something has happened, it's the female doctor or the nurses who will gather around and expected to sort out that thing. Right? Now the shift system in Sri Lanka is already in place for ICUs, ETUs, blood banks and so on. Right? So if a shift system is offered to these doctors who are giving up the state sector work because they can't handle this, we can actually retain them. Right? I mean, if you allow a flexi hours, some flexible arrangement that they can choose how many hours they can work, they can do, and of course they have to take a pay cut for that. You know, you can't collect 24 hours on call salary and be missing from ward for 8 hours, right? But if we actually, what if we become the devil's advocate and made ourselves honest? Would it be such a bad thing? Now, whether you're honest or not, you have to be dishonest because the woman has to pick the child from school. If you go to the preschools, international schools, state schools at 12 to 1 to 2, you can have a little get together of your colleagues there at the gate. Why? Why do they have to cheat? Because this system is so inflexible, because it is measuring the life of female doctors by the metrics of a man's life. Man doesn't have these problems, so no provisions are given for us to be honest or dishonest or whatever. You have to slip out and do this work, right? So can we have locum basis doctors? Can you go and you can do a locum for the state sector to an adjusted salary? We have to reimagine the way we do things. And we as a country struggling with economic crisis have to stop paying for things that people don't work for, right? So you have to reimagine another way. What if we one day wake up and do the unthinkable and be honest, right? I'll say I work for 4 hours, pay me for 4 hours. You're happy, I'm happy. There has to be some way you do that. And can we liberalize maternity leave? Right? Can we? I'm just asking you, like, okay, 84 days of working things, half pay, then full pay, right? So it's so rigid. What if you had a mother or a mother-in-law who offered to look after and you came back after half pay or full pay and say that person passed away, that person became paralyzed, the carer? I mean, can't you avail it? I mean, some kind of, why is it so inflexible? Why is this motherhood after birth is so linear, so rigid? Do we have to be like that? I think this system can easily reimagine these solutions. So the third elephant in the room is the sexual harassment and sexual violence faced by the female doctors in Sri Lanka. So in 2025, Manudi Vidanapatirana Kalanikula Tilaka and I did this study. It was published in Lancet. Damning evidence. Right? I mean, you wonder how they are not burnt out. That little percentage Kaumudi said were not burnt out. I mean, you wonder how they are not burnt out. Right? Probably because they don't think very deeply. If we all thought about all our problems, probably all of us will be burnt out. Right? 58%. 0.6% some form of sexual harassment, sexual jokes, suggestive looks, sexual remarks, inappropriate touching, attempted rape. Not that doctor. There are other doctors, right? So that is the one doctor we know about. But about the other doctors, we don't know about. So the three main themes that emerged from the qualitative analysis was they felt that anywhere, anytime, by anyone, I am in danger of sexual harassment. This included consultants, senior registrars, plumbers, floor patients, bed patients. The range is amazing, right? It is amazing that these people, these female doctors who choose to work in this country as an employee of that employer, Ministry of Health, is still working because this is how they feel, right? And then there is the pseudo normalization of sexual harassment. They did not know whether they should feel that something was wrong or not because it was so normalized. And 86% did not report it. Why? You will be labeled as the person who underwent this harassment, and the stigma will be yours, the shame will be yours, victim blaming will be yours, the breakdown of your family will be yours, everything will be yours, right? Right. So the perpetrator was a superior colleague. There you are, right? In that odd incident, the outlier incident last year, it was allegedly, we don't know yet, it allegedly a person outside our system, but well, 77% right here with us, right? So, practical solution 3, mandatory gender training for doctors and specialists. I ask you, most of you have good positions in these places, right? Maybe the PGIM should have a mandatory gender training for returnee specialists, to registrars. Maybe they should not even get board certification without reaching some kind of a benchmark. It is not a absolute like a vaccination against this, but the evidence is damning, isn't it? All right, practical solution 4, incident harassment reporting mechanisms. So first of all, the Ministry of Health and our whole country should accept that this is happening. Policy acknowledgement, right? Before we formulate policy. So you have to accept that it is happening. Secondly is empowerment workshops, specific education, awareness programs for female medical professionals, as well as the males, as I said in the previous slide. Then, of course, there has to be an establishment of safe, victim-friendly, non-punitive and confidential reporting pathways, right? And that should not be leaking information about who did it. At the same time, you have to make sure that this kind of a establishment should not victimize faultless men. It should not be used for revenge for other things as well. But just because there is a probability of it being misused, this doesn't mean we don't introduce a safe reporting mechanism to do so. So elephant number 3, the myth of women leaders. So we believe that when we have like a female, first female prime minister, second female prime minister, third female prime minister, one executive president, and so many people in parliament and women in very, very high-powered positions in different ministries, different ministers. We think that when we have women on top, this life would become less of a burnout for women. It's actually a myth. It's the myth of women leaders, right? What happens to women on top? Are these token leaders with all these people on top? What is our life like? I think Kaumadi has very nicely explained it to us, right? Do females on top enable females to have a non-burnt out life? They can't. Can they themselves survive in this situation? The thing is, you expect a woman to be in a leadership position and you think that woman will understand your plight as a woman. But if she were the kind of woman who would understand your plight as a woman, she would never be in that position, because she has to play the system made, designed, tailored for men that appreciate the highly masculine, adversarial constructs. You have to be that kind of a man-like woman to go and get it. So if you are like that, you are not that empathic, soft, maternal, enduring, nurturing. It's not. It is a paradox. So I'm not saying all of them are like that. All of us have had great female mentors, teachers, people who enabled us, protected us, supported us. For sure, I don't mean to demean them or diminish them, but as a system, if you are much like the virtuous woman with female virtues that enable people not to burn out, you're probably not going to meet her in a high chair. Elephant number 4, trivialization, stereotyping, microaggression, and discrimination. Okay, I have a little bit of time. Okay, so trivialization of women happens to all of us. Stereotyping, why should the women always make the flowers, the ushering, the I don't know, the secretary post, because they have those days nice handwriting. Now apparently you type nice, right? And then why do professional colleges ask female registrars to wear saris sponsored by drug companies and become usherers in conferences? Why are you even asking them to wear such clothes, which is an ethical transgression, right? Why do some conferences actually hire females who are very flimsily and sexily dressed as usherers? Why are we sexualizing, vulgarizing women in our own professional settings, right? And if you see, most of the times when a procession or a conference is about to happen, the organizing committee, it is the females in our profession who are there from 10 o'clock doing everything, right? All dressed up, and the men will join last moment, right? Female consultants will forego their private practice for that day if they have taken up a responsibility, right? I mean, the speak of truth has no friends. I might have lesser friends, but I'm going to say this nevertheless, right? So what about microaggression of nurses, of doctors, females? You know, as Kaumadi said, you know, they will attribute everything to Dulani's speciality. You know, they are like hormonal, right? And if someone is not married, oh, that is because she's unmarried, you know. And a male with similar traits will be a great leader, right? So how we stereotype and do microaggression. So personally, I think I don't agree to, okay, so I shouldn't say anything about myself, but I have consistently said, no, I will not usher anyone in my life. So there you are, right? So no, when they say like, oh, girls are tika kevan, nurses are tika kevan, in the hospital settings, even if there's an lecture and nobody is there to fill the hall, nurses laivanna, right? Junior doctors laivanna. Females, we are the fillers. We carry this burden, we carry this big dual trauma, right? And we are also supposed to be fillers. So when I was an administrator in a hospital, I said, no, if there are 10 people, it's good, it's fine, you know. No nurse is a filler for you, right? So these are the things. Okay, so practical solutions number 5, health professional education. So medical humanities, I'm not really trying to promote my field here, but medical humanities has a big role to play in using arts and the humanities such as anthropology, sociology, music, drama, cinema, for the discourse of understanding this. 30 years, it's been 30 years since Sri Lanka tabled a resolution in the WHO. This Professor Sarojaya Singh in the middle was the champion of this huge project. We also have Dr. Palitha Bekona and Dr. Anil Samaranayaka, who are our teachers. I think most of them are teachers and our teachers. They champion this because to incorporate this kind of understanding about the world and human nature and our lives into health professional education is extremely important. It is a solution because it can't come from this simply from Ministry of Health, as you can see. Yeah. So can we get there? Yes, we can get there. We are acknowledging that burnout is real, push for policy changes, and please let's all do a follow-up action from the symposium. We should not do token things. Okay, now the Women's Health Committee has done this. What has come out of this is, I think, is very important. We should not do token activism, just the way we should not do token ushering, right? So partnership and collaboration with Ministry of Health, PGIM, professional colleges to sensitize both men and women and adopt some policies, even the tiny policies like, our PGs will not wear low-cut blouses and saris given by drug companies to usher from there to bigger issues like gender sensitization and policy changes and push for change. And I think we all need to be an example of all these things that we preach and trust in the power of the health professional education. That is very important. It has to be embedded into curricula. Detection of burnout, responding to burnout has to be a part of our discourse. I'm going to ask you, these are some ladies, they are female, our nurses protesting when that incident happened last year. This is solidarity, this is sisterhood. I love this picture more than the doctors striking. Right? This is solidarity, this is sisterhood. So are we candles in the wind? I think we are. Right? So I was discussing this topic with my friend, Professor Diniti Fernando, and I said I want all of us to be like this aspirational lamp, which is mentioned in the Bhagavad Gita. Bhagavad Gita says you must transcend all these worldly worries and stresses, and you must be like a lamp in a windless room, in windless place. The lamp in a windless place is not a candle in the wind. It's not about to burn out. So she said, no, I don't think that is very practical, because that is once again a moral burden we are putting on women. Be like a lamp in a windless place while making her whole life go topsy-turvy. So she said, no, please find a different thing. Please don't say this. But I said this anyway. So I found a better example from the Sri Lankan culture. We have much to learn from our own culture. So this is the Dolos Mahe Pahana. You can see it in Pansal temples as well as it's called Akhanda Deepam. It is seen in Kovils as well. That lamp doesn't go out. Why doesn't it go out? This is the Dolos Mahe Pahana in the Dalada Malgaon. I think you can temple of the tooth relic, right? Because it's protected, right? It has a structure that protects. It has a slowly, the oil is not put in a gallon. Slowly, it goes. The work is slow, it's measured, it's controlled. And there is something always protecting. I look at policy, our own changes, our constructs of good constructs of thinking as this. So if you can't burn like a big fire, you must not be a candle in the wind. We must make the female workforce in our Sri Lanka like Dolos Mahepahana. So throughout, they can nicely give this soft, nice light. And this Dolos Mahepahana is a very beautiful thing. I mean, this is not a very beautiful picture, but it's a very beautiful thing because it's forever giving light. It's not burning, right? It has a very soft fire, you know. So yeah, so can we be Dolos Mahepahana, right? So I think that should be our aspirational thing, not to be a candle in the wind, not to be a lamp in a windless place, right? That is for our more philosophical end of life, I think, but to be a Dolos Mahepahana as we go on this life. With this, I want to pay tribute to this great lady. I think most of us who ever had a child who's still in this job is here because this great lady pushed for policies for maternity leave for Sri Lankan women. I think beyond her this scope, no woman has actually been able to push for this kind of significant policy in Sri Lanka for the doctors, nurses, the women of Sri Lanka. Deshamane Priyani Soisa, I think everybody knows her. She's a professor emerita of pediatrics. She made this whole world different for us. If we are here today, it is because people like her pushed for policy. I think this level of policy change, this sort of advocacy, this sort of fearless engagement with the state, and not having any kind of fear in protecting and fighting for the rights of this sisterhood of this profession, that should be our aspirational, like a North Star. That should be our North Star. And I pay tribute to her as I wrap up my presentation, and I dedicate these 30 minutes that I have spent thankfully on time to Deshamanya Priyani Suisa. Thank you.
Thank you, Santosha, for that. I would say I was mesmerized by your suggestions, which are very practical, and I felt some are really doable also. And I would like to, from the SLMA Women's Committee, uh, I have been in the committee for many years. One of the good things, I think, Sampatha, you may remember, regarding sexual harassment, we were the very first committees to address and make a format in the investigation in the Ministry of Health, but the system was much discussed, published, and piloted, but implementation was again was not there. So time to time, I know Women's Health Committee of SLMA has been in the forefront, and last year with that unfortunate incident, we have been actively participating, and in the Ministry of Health there is a committee to a technical committee formed to look into all the aspects and ensure a protective, a safe place. And SLME Women's Committee with the other stakeholders are there working. And with this today's symposium, I really felt this emerging thing is an area where we should actively do some advocacy. And it's now time to open this for questions and answers from the audience here, as well as anybody who is online. You are most welcome to put your questions to our three panelists who are here, the resource persons. I have one here online, Madam Padma Gunaratna, who has raised her hands. Madam, you can raise
Yeah.
your question, either type it or you can.
Yeah, Anuruddha, thank you very much for organizing this symposium. Very timely. And for all three, I congratulate all three speakers for this very impressive type of presentations.
Give me a minute, madam.
Can you hear me?
Madam, you can
Yes.
put a message and then I will read the question. In the meantime, whoever in person, you can ask any questions, which if the and to any person who is here.
I think on the side of the Ministry of Health, actually, these unsafe living spaces, lack of quarters, lack of safety is across genders. When that incident happened last year, this was highlighted. And there was a public call for, not public call, actually call from the community of doctors, male and female, to ensure these spaces. But on policy, Ministry of Health has to provide these facilities if we are getting this service from the people. It is there in black and white paper. We have, I think, probably, I can't say talk myself, but as unions, as even forget the unions, as collectives of females who are affected, these have been asked in many instances. I think in Sri Lanka, across ministries or departments or across sectors, this buildings, securing them, ensuring standards are not up to the par. But as for the policy reforms about, I think, liberalizing these working hours, flexi hours, I don't think there has been a real discourse. But what I want to say is this provision for shift work is an already accepted model in the Ministry of Health. Actually, we can never get out of this rut of being a developing country forever if we have very low national productivity. If we keep paying for things or work that is not done, not just by women, by anybody, we cannot overcome these economic barriers. So I think it is much better, although it's difficult probably to operationalize it, maybe piloting some hospitals, maybe there has been a discussion about making Saturday, whether you can reimagine if the ways of operationalizing hospitals on Saturdays. I think these are policy matters that can be changed. There is a model to do that. So I think there is an opportunity. That's what I think.
Dr. Padma Gunaratna has said, let me congratulate all the present presenters and you for organizing this wonderful symposium, which is timely. Could the Women's Committee organize a stronger program for the doctors in order to pressurize the ministry to safeguard rights and security of female doctors? If doctors start it, it would be automatically spread to other professions. So part of the question I think you have asked, I think as the chairperson, when it comes to advocacy, SLMA is a very strong front, which has been doing their job maximally over its history of more than 100 years, definitely. And this emerging topic is something actually we have started, but a stronger not only advocacy but policy level drafting, making strategies, that level we have to get involved. And most instance, as Santosha said, there are different mechanisms are there, but the issue is from the hierarchy to the they recognize it when something happens, but the sustainability is a issue. I don't know how. Maybe from the audience, any bright ideas about sustainability? Because yes.
Came into my mind. Now, I see this health ministry has already introduced the CPD points. People are collecting CPD points. I don't know for what. Maybe for their increments, what they are using it. I don't know. Health ministry, MOSA, now attending these CPD activities and collecting points. Similarly, why can't we do for the professionals, not only the trainees, to have some PTRs from the peers, peer team ratings, like, because most of the sexual harassments were from the senior colleagues, senior people who are supervising the junior doctors. So the PTR is a good thing for their promotions, for their increments or whatever. So that is something sustainable within the profession to stop or limit this. One suggestion.
Sandusha, do you have any suggestions for sustainability? Because we do things, we suggest things, but it's the system has to implement and make sure things goes into the system, not when this particular leader or this person is in the ministry, it's functioning. When another person comes to the same post, it become non-functioning. That sort of a thing is not the way.
I think, Professor Anuruddhi, we can, this complete overhaul doesn't work. Because actually we as a society are in denial also. No? We don't want to believe that it is so. So I think we can start in an incremental manner. For example, we can introduce it for internship. Maybe they are the most vulnerable when sexual harassment or any other kind of bullying, or I mean, not only, I think we should not keep saying it like that to give our male colleagues a bad name. It's not like that. Other kinds of bullying, a mechanism that internship, we have to educate the consultants also. These are, we have to spell it out, we can't speak in rosy, poetic, this mercurial language won't do. These kind of comments you can't make. Like, it's not just sexual comments, like even saying like that is not a bad word, but you can't say. So we can actually do a sensitization for the internship period, and also there it has to be tied with a repercussion that interns will not be sent to your ward if there are such a number of thing. And these anonymized, protected mechanisms of reporting, that has to be there. And same with the PGIM. I think the PGIM can only, in one hand, have a gender sensitive sort of efforts embedded into their curriculum. It can be made mandatory for all PGIM courses, and PG trainees also will not be sent to, not only for sexual harassment, other forms of harassment. And to be de-recognized would be a very bad thing for that person. And I think people will take their checks and balances. Otherwise, we can't go and suddenly go on this very on a feminist hall, that should not, that can't be the way in Sri Lankan culture and the Sri Lankan system. But one thing is that. Other thing I think is that through these professional colleges, if we can make SLMA as the primary, the apex body, like, why can't we say that some small things like what I mentioned, madam, it is happening, isn't it? Is it right? I mean, even if you are not using our PGs, and there's a huge power imbalance now. You can't say I won't be Ashara. Can you say? You can't. And you see, and also not use other women also, even professional. It is very wrong for women all over. So I think professional body and increments to do that. That is one thing, that is for harassment and burnout. And but I think for other things like this work covers, to the Ministry of Health to have a lactation room. Podi babek paragan, if there has some problem, some chance, place to sit, some mother-friendly quarters. I mean, we are losing our healthcare workforce, and we are losing our country's investment to other countries that has things. And also, like, injudicious opening of new units in hospitals. And women, because they are more pliable, and you can force them to do these things. You open new units and 2 MOs. And when do these ladies go home? At the whim and the fancy of consultants, you can't do that without sustainable human resource allocation. So I think these sort of things are not big. They are not very bright ideas. They are common sense. I think so. We, as the Women's Committee, madam, you can be the champion. I mean, you all, not you. You all can be the champion to write a letter at least.
Definitely. It's a great idea, and the time is 10 minutes to 6. I will encourage another 1 or 2 questions and answers maximally.
Thank you to all the panelists. I think it was an excellent discussion, and in fact, it brought to Mr. Miles listening to. So what I feel is, most of the things that we do to other people is due to generational trauma and type of behavior that we have experienced during childhood. So looking at all the data we presented today, I said that this is a highly rampant, it's like a disease. And where do we start? Since many women will be listening to this, how do you bring up your children? In fact, in a country like ours, where I feel we will have a lot of exposure to peaceful religions, Muslim, Islam, and other religions which are peaceful, and they are considered a very cultural society. So, what kind of advice do you give to young partners to prevent children from being brought up this way, to dehumanize women here and to talk like this to behave in this way. Even women tend to do that when they are, as Madam mentioned, that even administrators who are women tend to treat women that way. So, where do you start as a mother? I mean, I would like to know if any of you could answer this.
Santosha.
No, I think that is right. So I think that's a loaded and a pertinent question. I think that is why you have laws. You see, one thing is that whether you are a enabling humane leader or not, there has to be laws in place that even on a day you are not feeling very humane or kind, you don't have the provision to be so. So I think one thing is the laws. The system has to be in place, as Anuruddhi said very rightly. It can't be depending on when, as long as a nice consultant is there, when she or he retires, the good days are over. It can't be like that. One thing is that. Other thing is, as I mentioned, this our role in medical humanities is to do that. Actually, this is very important. From the day you enter medical faculty, you start with dissections. You have to know, obviously, you have to. So, you are. The underlying message is body is, you're cutting it. You see, it is a utility. It is the human body is presented in a utilitarian manner. But now many faculties do, like dana, kirit, respecting cadaver as a teacher. So they are doing all these things. That is actually medical humanities at play, and I think it is very important to be advocates. That's what I say. We have to be champions for the reforms of education by and large, to have these elements of in our education dedicated to understanding human nature. It is a top down and bottom up both. So but what I feel is that laws, regulations, repercussions, feedback mechanisms, anonymized pathways for people to submit grievances, these are extremely important. Otherwise, no matter what education reform, whatever does, for that odd person who might cause these problems, there has to be a deterrent. I really think these two things are.
And one of the persons in the Zoom, Justice Jayaki writes regarding the law and the deterrent part. She said to minimize burnout in medical profession, to say about remedies in law are compensation, discrimination claims, or civil lawsuits are available. And further, she said, this is an era, the legal landscape is shifting from viewing burnout as a personal wellness issue to a legal liability for the employers, which you correctly said, for victims. Help through legal action generally follows about three pathways. So, which is said about compensation and so forth. I think we definitely, in earlier attempt about the sexual harassment reporting mechanism, which we have done it in earliest 2014 or yeah, somewhere around 2014. We have to revive that again, Santosha, and do more to maybe revisit it to suit the present context, and go for the implementation, and make sure that the deterrent effects through administration is definitely be available. And one of the other things which came into one of the comments which you made are people, because we have to do things for very Sri Lankan specific. But the same people, when they go abroad, the way that how they work, the respect they give, the book ethics they practice, uh, is their santosha. But the same person coming and working is not so. So it's a part of, as you say, it's a paradox. But then how to get that societal paradox? At least we should be champions in this profession. It's a very powerful profession where ethical part, professionalism is in its highest. I, of course, don't have, but it's an area where.
So I seem to be dominating the responses. I'm sorry. But I think that is why, in those countries, you can't, there are repercussions. If you do this, you will be delicensed if there are X number of problems. So that is the repercussion. But our real aspirational model should be that this compassion, empathy comes from within. In those countries, maybe they are actually feeling empathy or no empathy, they will conduct with empathy. But our aspiration should be that all this should come from within. But at the same time, Prof. Anuruddhi, those countries, the patient to doctor ratios are very low. You can take your time and you're not overburdened. Here, we are forcing people, even after 24 hours duty, the next day also you are expected to work till 4 before you're released. And because of this lack of regulations and lack of mechanisms to report, right? Not only, you must never vilify specialists or heads of units, right? There are MOs who make the rosters, where people who gang up against certain people. So there are so many other dynamics that will never be tolerated in a resource-rich country. Actually, we are forcing our nurses, not only our doctors, especially nurses and healthcare workers, they are under the iron rule of matron sisters. I think we have a lot more agency than that. So I think that is one of the reasons. We always think that our country is hopeless or our economy is hopeless when the whole world is a bit hopeless. But one of the main reasons that people, this outflux of nurses, more than the doctors, is because their working conditions are very, very regimented and it's not, sometimes they don't see their children for days. Even if the child has dengue or fever, they are forced to do back-to-back work. So I think more flexibility, more women-friendly policies, and even at a cost, if you retain the doctor, because the children are not going to be small forever. If you help this female doctor, female nurse overcome this little window, imagine our gain on investment. Otherwise, we become cheap factories that make great doctors and nurses for the West. That is what we have become. The best of our nation, the treasure of our nation, we are sending because we can't get our head around helping them overcome. But 10 years, maybe, but they will work for another how many years? So we have to look at it in economic terms as well.
Right. I think I have to make it a make considering the time to say the question and answer session is over, but we will definitely continue as the Women's Health Committee, and our Vice President of the SLMA is also a resource person here. And I sincerely hope you will, Dulani, you will take up this message to the council, and as the Women's Health Committee, we are ready to take up any challenge regarding as our topics day, to give to gain, right? So I invite to do the closure to come to the podium, Dr. Rajika Savanadasa.
On behalf of the Women's Health Committee of the SLMA, I would like to thank the distinguished panelists for a very interesting and enlightening session today. I'm sure all of us had a lot of questions which were answered, and I'm sure we would try to make this world a better place by addressing all the issues that were highlighted today, or at least some of them. And also like to say thank you to the audience who has been interactive as well as for staying with us throughout this session. Thank you once again and hope you have a pleasant evening. Good night. Please join us for some refreshments now.
Yeah, we'll take